We will now begin Unit 2 in the OB course. Unit 2 is the intrapartum material, content, chapter. We'll be going over chapters 16 and 17, giving birth and intrapartum surveillance. If there's material in these chapters that's not included in this presentation, then that means that it will not be on your exams. Our learning goals for this chapter are going to be discussing the response by the fetus and the mother during the process of labor. We're going to discuss how will the mother know when her labor is impending or coming, and those are called premonitory signs of labor. Discuss what makes true labor versus false labor. Look at the stages of labor, what occurs during each of them, what nursing interventions and assessments we may want to do during those as well. Discuss electronic fetal monitoring, how it's done, what the results may be, how to interpret them, and what kind of nursing interventions we want to do from those. And then list some interventions for those electronic fetal monitor strips that are not reassuring for us. Physiologic effects of the birth process in terms of the mom. I'm going to let you read this on your own, but you can see that there certainly are significant changes, especially here if you notice that during each uterine contraction there are 300 to 500 milliliters of blood pumped into the general circulation. I think we talked about that a little bit when we discussed Pitocin last week, and how that can cause fluid overload and can be a very significant event during the process of labor. Otherwise, please look at these and we'll look at those yourself. This diagram is a diagram published by Lamaze, and they have 6 healthy birth practices that can all add up to good outcomes for mother, fetus, and newborn if followed. At the bottom there is a short video that you could look at, and there's some resources on that, and I'll let you do that on your own. But we would like for all women to start with spontaneous labor. We'd like for them not to be medicated too soon so they can be up moving around. We'd like for them to have continuous labor support by their nurse, by a doula, by their partner, but by someone to feel supported. We would like for them not to have routine ruptured membranes or routine administration of any kind of medications, including IV push narcotics or epidurals. We'd like for them to be in a position where they can utilize gravity to help them push that baby out. And that would be in an upright and spontaneous pushing, and then keep the mom and baby together afterwards. So maybe even delaying our complete assessment and administration of medications on the newborn for the first hour so mom and baby can bond. This is a video with 7 women describing their birth experiences. I think you might find it interesting. I won't show it here, but some of these women had a positive birth experience and some didn't. And the reasons that they didn't might, or in fact might not, surprise you. Many women have the idea of how they want things to proceed during labor and birthing, and if it doesn't go that way, it's a significant event to them, and in fact can place them at a very high risk for even postpartum depression. So please, if you have time, take a look at that. It's only a few minutes long. So the physiologic effects of the birth system, birth process, in particular talking about contractions. I'm probably going to go over this in class as well, but contractions have 3 parts, and the part where it begins to increase is the increment. So IN for increase and IN for increment. That's when the contraction is building in pressure. And then right at the top where it's the most painful, the most contractile at all, is called the acme. Sometimes you'll see that also called the peak or possibly even the nadir. And then the uterus starts to relax and decrease in the contraction strength, and that's called the decrement. So DE for decrement and DE for decrease. The frequency of the uterine contraction is measured from the beginning of the contraction until the beginning of the next contraction. So from increment to increment, that's the frequency. This is important for us to know and for the patients as well, because many physicians' offices will instruct the patients to come to the hospital either when their water breaks or when their contractions are X minutes apart, perhaps 10 minutes apart, depending on if they're multigravida or primip or if they've had fast labor before. But at some time they may tell them to come. Now, the duration, I'm going to skip down to the duration. The duration, of course, is from the beginning of that contraction until the end of that contraction. Those two things only, frequency and duration, can we measure with an external fetal monitor. In order to measure the intensity on a fetal monitor, we'd have to have an intrauterine pressure catheter, which we will take a look at in the classroom. The intensity otherwise will be measured by palpation. When we press on our forehead, for example, well, let me back up. Let's start with our mild intensity. Mild intensity feels like your nose. If you press on the end of your nose, that means that you can press into the uterine muscle during the contraction. So you'd be palpating, and fairly deep palpation so that you can feel the muscle. And then you'd see if you could press your finger into it. If you contract your arm or leg muscle now, you could feel that the muscle is contracted, but can you press into it? And that would be mild. If you can press in significantly. If you can press in only a little bit, it's sort of like pressing onto your chin. There's some tissue, but then you feel some hardness underneath. And if it's a very strong contraction, it'll feel like touching your forehead. You won't be able to press into the muscle at all. So with palpation, it's mild, moderate, and severe contractions. And again, it's measuring really how much we can press into the muscle of the uterus during the contraction. And only the frequency and the duration can be measured on an electronic fetal monitor with external attachments, so with the toco on the fundus and the heartbeat. We'd have to use an internal uterine pressure catheter if we were going to measure the intensity. Of course, the cervix is what makes the real change. That's what really differentiates true labor and false labor. Are there changes in the cervix? Is the cervix dilating and effacing? And it goes from 0 to 10 centimeters of dilatation or dilation, and it goes from 0 to 100% of effacement. This can be somewhat subjective, so during the process of labor, if it's possible to have the same person primarily be doing the cervical checks, then that's an optimum situation. This is not, as you see it, true to what you see. However, a 1 centimeter dilatation looks sort of like a Cheerio. So when you put your finger up, you feel the opening, and it feels about like a Cheerio. And of course, then a slice of banana is 3, crackers 5, soda can 7, and a bagel is 10. Most of us with small hands, of course, can't do the 10 all at once, so you kind of have to feel around the rim and get to know your fingers and what they will measure. So this slide will give you a visual representation of a cervix that is not effaced, so it's still thick. Effacement is the thinning of the cervix. An average woman's cervix will be anywhere from 2.5 centimeters to 4 centimeters. We're all different. Just like our noses are different, our cervixes are different lengths. So anywhere from 2.5 to 4. So as it begins to thin, it will be measured from 0 to 100% effacement. Again, it's subjective. You may not know where it started, so we just know that it's thinning. And when it's very thin, it's like paper thin, and we can't really feel anything at all, which is what it feels like down here. You can't really feel any cervix at all. It's gone. And when you do feel it on the edges, it feels like just a little bump. So the cervix will thin, and then as it shows here, it will begin to open up as it shows in this box number 2. And then number 3, the cervix is dilated 5 centimeters, and then 10 centimeters is completely dilated. So again, cervical dilatation goes from 0 to 10 centimeters, and effacement goes from 0 to 100%. And this is what happens during stage 1 of labor in all phases. Again, another representation of cervical effacement and dilatation, perhaps to help you. I would say that please ask your clinical instructors to get the boxes of cervical dilatation and effacements that are in, I believe, all of the facilities that you're in. They just need to go to where they store them, which is usually labor and delivery, because they use it for their education as well. And ask your clinical instructor if they can find those for you. They're not perfect. They're not exactly like humans, but it might give you a better representation. So you can see here in the first, on the left side, no effacement, no dilatation. Cervix is still really thick. And then it begins to get thinner and to open up. And around the top, on the top line, it shows you the effacement, and the bottom line shows you the dilatation. This is just yet another representation that may help you get an idea. The picture on the left is like an old-time ketchup bottle. The picture on the right is an old-time mayonnaise bottle. So no squeeze bottles or anything, just old-time bottles. So the ketchup bottle represents a long neck, which is no effacement, and a very tiny hole, so no dilatation. And then the mayonnaise jar represents a very small thickness to the neck, let's say. So that's effacement, 100% effaced, and then a really big opening in the top, and that's 100% dilatation. So if you think about that, ketchup bottle, no effacement, no dilatation, mayonnaise bottle, complete dilatation and effacement, that might help you understand as well. Cardiovascularly during the process of labor, of course, most significantly is the ejection of the blood flow from the uterus, 300 to 500 milliliters, with every contraction. So if we have very long contractions, very, very frequent contractions, hyperstimulation more than what we would consider normal, then our patient is always going to be at risk for fluid overload, and we need to make sure that our assessments include assessing for that. Positioning is primarily encouraged to be on the left side, as usual. Hyperventilation is not uncommon during pregnancy. And what is the treatment for hyperventilation? That's right. It's a paper bag. Breathe into a paper bag, because with hyperventilation, they've blown off too much CO2, and the symptoms that they get will be dizzy, tingling in their fingers, that sort of thing. So have them breathe into a paper bag, not a plastic bag. The GI tract experiences a great deal of decreased motility. For this reason, we do not want to put anything significant into their GI tract once they're in active labor. Many facilities and certainly birthing centers would allow some type of light food or drink. Probably more reasonable to just go with liquids. And amazingly, God, Buddha, Allah, Mother Nature, Yahweh really takes away the hunger from the mom during the process of labor anyway. So they're usually not asking for food during the process of active labor. We do want to keep them comfortable, so keep their mouth dry, give them sips, or whatever the physician's orders are, give them sips or clear liquids or ice chips, or some swabs to keep their mouth dry. That's one thing that the support person can be enabled to do. When we give the support persons a job, especially those that haven't really gone through any process of education, they feel useful, and they appreciate having something to do. So that's always a nice idea. In the urinary system, the woman will experience decreased sensation of her bladder filling. For this reason, assessment of her bladder and her I&O are critical events for the nurse. So you think, well, we're never going to forget that, but I assure you that it is forgotten. And the reason that it's important, two reasons, of course. If you leave urine in the bladder, then that can predispose them to a bladder infection. And the second reason is a full bladder takes up space and won't enable the fetus's head to descend into the pelvis. In fact, it can almost completely stop labor. And I've seen this many times over the years, and so have my students at times as well in previous semesters. The bladder fills up. Labor, which was going on quite well, now you can see by the monitor, is quite slowing down, not looking like she's making much progress. They drain 500 milliliters to 1,000 milliliters of urine out of the bladder, and boom, picks right back up, just like it was before. So that's a very nice thing to do. Blood loss, of course, we do expect some blood loss. With a vaginal delivery, nothing over 500, and a cesarean birth, nothing over 1,000. Those would be considered postpartum hemorrhage. So a vaginal, less than 500 is normal. Cesarean, less than 1,000 milliliters is normal. WBCs will often go up during the process of labor just as an inflammatory response, not really representing a true infection. Mothers remain to be hypercoagulable during the process of labor. Now let's focus on the fetus a little bit during the process of birth. The circulation to the fetus, of course, decreases with every uterine contraction because those muscles in the uterus are really, really strong, and they're contracting around the blood vessels that are coming into the uterus, and in fact those into the placenta, so it slows down the blood flow. Normal, healthy fetuses are used to this process, and they can tolerate this process quite well. If they cannot, they will send us a message, hopefully, through the electronic fetal monitor to let us know that they're not doing so well. And we'll talk about what that looks like in just a little bit. Fetal heart rate should do what during labor? What would we expect to see as a sign of fetal well-being in terms of the fetal heart rate? That's right, accelerations. Accelerations are always a sign of fetal well-being. And just like when we used them in an NST with 15 by 15, certainly we'd like to see that. But any kind of acceleration during the process of labor on the electronic fetal monitor is a positive thing. All fetuses have about 100 milliliters of fluid in their lungs during the process of a vaginal birth. Most of that will be, let's say, squeezed out of the lungs, and what remains will be absorbed by the lymph system. Those babies born or fetuses born by cesarean may not have the benefit of having this fluid squeezed out of their lungs. So this could be a problem, having a little bit of retained fluid in their lungs after the process of birth, which we'll talk about in a following chapter. That's transient tachypnea of the newborn. Now this is a diagram that I made several years ago, and one thing is that it may not exactly match the dilatation per your textbook. And I make this and show it to you because I think if you develop something like this could be called a concept map or a Venn diagram. If you use something like this to help you see overall the process of labor and birth, you might find that it's easier to assimilate and learn the material. It's not required. You can certainly use this one. You have access to it now on this PowerPoint presentation. But I made this by going through the book and looking and reading. And by that process, of course, I learned, and during that process, so would you. I think the value is in doing it. It's not memorizing it. And I've told you that many times. If you want to learn something, you have to have an active participation in it. So I would encourage you in many of our lessons, but certainly in the process of labor, to develop something like this. Now, the components of the birth process, we have the 4 P's, we call them. Those are the powers, the passage, the passenger, and the psyche. The powers, of course, are the contractions, not only the uterus, which is an involuntary contraction, but also a voluntary pushing by the mother, using her coccygeal muscles, using some abdominal muscles, not using her facial muscles or her eyeballs to push, but to push down low. The birth canal, we have very little control over that. In fact, I think we have no control over that. That includes the bony pelvis as well as the soft tissue of the vagina and the perineum. The passenger is the fetus, and the fetus does have an active role during the process of labor. It makes some different movements in terms of flexing its neck or not, which can facilitate its downward process through the birth canal. And then, of course, psychologically, emotionally, we can understand how some women who've had a poor outcome in the past, or are alone, or have lost their spouse to divorce or death or murder of some kind, then they may be in a different psychological place. Perhaps they're planning to place this infant this fetus when it's born for adoption. You can imagine how all of these things may have an interest in how they react during the process of labor. And as we do our intake and assessment on our patient, we'll have a better idea of what we can expect from them. Okay, so back to the passenger's fetal head. You see the suture lines. Those are just the spaces between the cranial bones. When we're doing our vaginal exams and palpating the cervix, once the cervix is dilated and the bag of waters is ruptured, so we can actually touch the fetal head, we can use these markers, the fontanelles and the suture lines, to help us know what position the fetus is in. Optimally, because if we feel the posterior fontanelle, it means that the smallest part of the fetus's head is in the pelvis first. That's most advantageous to delivering vaginally. So we would not want to feel the anterior fontanelle or palpate it during the process of a cervical exam. The other consideration for the passenger is the fetal lie. On your left is a longitudinal lie. That means that the fetus's spine is going the same way as the mother. So it's longitudinal. Even if in that picture we flipped that baby up into a breech position, it's still longitudinal lie because the spine of the fetus and the spine of the mother are going in the same direction. So there are only two possibilities here, longitudinal, or on the right you see transverse lie. Please use the whole phrase transverse lie because that means something entirely different than the position that the fetus is going to be inside the pelvis, the place where the head is, and we'll talk about that in a little bit and also demonstrate during class. But there are only two positions for fetal lie. Again, on the left, longitudinal lie, that can be butt down or head down. Either way, the spines of the mother are going and the fetus are going the same direction. On the right, the transverse lie, the spines are perpendicular. Now, of course, the fetus doesn't lie exactly straight across, but we'll demonstrate that in class as well. However, their spines are perpendicular. In 2014, this fetus is always delivered by a cesarean. The passenger in the fetal attitude. Now, the fetal attitude does not have to do with whether this is a cranky baby or a happy baby. It has to do with the relationship of its parts to one another. And flexion is what we would like to have. So the fetus will be flexed, in the flexed position. Okay? Knees, hips, elbows, and neck are all flexed. I'm going to go over this in class with the pelvis and the fetus to demonstrate, but the presentation of the fetus can either be cephalic or breech or shoulder presentation. In a cephalic presentation, there are 4 variations: vertex, military, brow, and face, and these all have to do with the flexion of the neck of the fetus. Optimally, vertex is the presentation that we want. This means that the chin is flexed onto the chest. That helps to present the smallest diameter of the fetal head into the pelvis first, so that will facilitate the process of birth and vaginal birth. Unlikely that military brow or face will be delivered vaginally unless you have a very optimum pelvis and perhaps a small fetus. Otherwise, those will probably be delivered by cesarean. In the breech position, there can be frank, full, or footling, and I believe I have some pictures here to show you of those in just one moment. So these are some cephalic presentations. This is a vertex presentation, so if you can look at that far left-hand picture, look in the middle of the pelvis, the smallest diameter of that fetus's head is there. As we go across the way, moderate flexion, or the military presentation, you can see that it's larger, a larger part of the head. Now go back and look at the vertex presentation. Which fontanelle will you be able to most likely feel? You can see on the right, if you look at that bottom picture of the pelvis, that's like looking down at the pelvis from their head. You can see that you'd be palpating the posterior fontanelle, and that's optimum. As we move across, military presentation is moderately flexed, and look down at the bottom. Now we've got primarily the anterior fontanelle. Again, not likely that this fetus will be born vaginally. Move over to the brow presentation where there's poor flexion, so the neck is not flexed at all. In fact, it may be extended. And you can see again, not only do we see the anterior fontanelle, but now we can feel the brow. That's why it's called a brow presentation. Full extension, so the neck is fully extended back, the total opposite of flexion. Complete flexion on the left with the vertex, complete extension on the right with the facial presentation. And in fact, when you palpate, you will feel a little smushy mouth, nose, eyeballs. And I assure you that if you're competent in your cervical dilatation and cervical checks, you will be able to tell the difference between not only a head, hard part of the head, but a soft part of the face, or even soft part of the buttocks. These are examples of the breech presentation. The frank breeches are so funny because when this fetus comes out and is born, the newborn's legs stay like that in that position. And like I've stressed before, if you learn to say it, then you won't the correct way and use the correct anatomical words, it'll be easier to remember. So in a frank breech, both the hips and the knees are in the extended position. Okay, they're extended out. Whereas in the full breech position in the middle of your screen there, both hips and knees are flexed. The single footling breech on the right is just an example of a footling breech. That could also be a double footling breech. It could also be where the feet are just barely hanging out into the cervix, so you don't see them out of the vagina, of course, but they're just barely. But it doesn't matter because this is always an OB emergency. This is a cesarean birth, immediate, urgent emergency process. This is the transverse lie fetus. So as I said, they don't lay completely perpendicular in the pelvis. It's more like the shoulder kind of falls down into the pelvis, or the acromion process. So that's called a shoulder presentation or a transverse lie. Very rare that you would feel this in the process of labor, because we would most likely know this through our Leopold's maneuvers, excuse me, or ultrasound, and this patient would also be scheduled for a cesarean birth. Now, way back in Caesar's time, caveman days, Daniel Boone days, this would have been a delivery where probably the life of the mother and the fetus would be damaged or not survive during the process of labor. They would reach up there, turn this baby or fetus around, and try to birth it that way, which would, of course, not work in most cases. I'm going to save most of this for the demonstration in the classroom. The fetal position of the passenger, the position is important to determining whether this is an optimum situation for the fetus to be birthed vaginally or not. I call it alphabet soup because even though on the right-hand side of your screen there you see that the words are completely written out, starting at the top left, left occiput anterior, right occiput anterior, and so on. We really see those as abbreviations. LOA and ROA would be the corresponding ones for those positions. In that being said, I will tell you in the clinical setting, often it doesn't really matter if it's on the right or the left, so you may not hear these complete ROAs or LOAs or even left occiput anterior, right occiput anterior verbalized by the nurses and physicians in the practice, but you will hear them say that the fetus is anterior or posterior. That's really what's most important, because when a fetus is anterior, it means that it's most optimum for a vaginal birth. It does not have any very far to turn, internal rotation, the fetus doesn't, to be birthed in the anterior presentation, which is how they are birthed in the easier way. If a fetus is in the posterior position, this places the hard part of the fetus's head against the tailbone of the mother, and this is where we experience back labor. These labors can be very unrelenting and very long, difficult labors, because now that fetus has to turn all the way around before it's born vaginally. And so that is not optimum. So again, occiput anterior, right or left doesn't matter, but OA is most optimum for a vaginal birth. Posterior, right or left, it doesn't matter, but occiput posterior presents mostly with back labor. And we'll demonstrate this in the classroom with the pelvis and the fetus. So what causes labor? What stimulates labor to begin? Well, there are some theories, but no one knows exactly why labor begins. We know that during the end of labor, the end of pregnancy, again, towards 38 to 40 weeks, that the woman experiences a decrease in the progesterone level. And if you remember, progesterone maintains pregnancy in that it relaxes the uterus. So as that level begins to decrease, the uterus can be more excitable, let's say. Prostaglandins are excreted by the fetus, the decidua, which is the pregnant endometrium of the uterus, and by the fetal membranes. These prostaglandins are chemicals that can cause the uterus to become irritable and to contract. In addition, the fetus will secrete some additional cortisol from their adrenal glands, and this also stimulates the uterus to contract. And then overall, just the stretching and the pressure and irritation of the uterus and the cervix as the fetus gets larger and reaches its term size can also stimulate labor. So we don't know all of the reasons or the reason, but these are some of the possibilities. Now, premonitory signs of labor are signs of labor are signs that labor is impending or about to come. They're not absolutes or guarantees, and some women will experience them and some won't. I'll talk about Braxton Hicks in just a moment. I'm going to skip that for this moment. Lightning is what laypersons call dropping. So as the fetus engages into the pelvis, some women will even say to their friends, "Oh, you've dropped. You're really dropped now, and you're going to have your baby soon." Well, it's most obvious in a nullipara, someone who's having their first baby. And in fact, the fetus will visibly descend into the pelvis. And if it's not visible to others, it certainly is felt by the mother, because now she'll be able to feel like she can take a deep breath. Nice deep breath, and also she'll be able to eat. Her stomach won't be so compressed by the gravid uterus. Vaginal discharge will increase, and sometimes it will be slightly blood tinged, or the mucus will have a little bit of streaking of blood in it. That occurs because as the cervix begins to stretch and dilate, small capillaries will be broken. This should not be absolute bleeding, but a little bit of blood tinged is not uncommon in the early phases of stage 1 of labor. Now, when you're in the labor process during the hospital stay, you may notice that the bleeding increases, and that will occur. But in the beginning stages, it's just bloody show. Then many mothers have a nesting or spurt of energy that comes right before labor ensues. This is where they want to get those last frozen meals in the freezer, get all their laundry done, notes to everybody what to do when she's in the hospital, pack her bags, one more coat of paint on that rocking chair, etc. Want to encourage our moms to rest a little bit, because they don't call labor vacation, they call it labor. So I don't want them up all night doing things and then up the next day in labor. Some women will have a small weight loss, 1 to 3 pounds right before labor, and that could be because they're ridding themselves of some of the extra fluid that they've accumulated during pregnancy. And I'd like to also add, what's not on here is loose stools can sometimes occur. All of those prostaglandins that are being secreted by the fetus, the decidua, and the fetal membranes can cause the other smooth muscle of the body, in addition to the uterus, to also be contractile, and that includes the GI tract. So those prostaglandins can cause loose stools, not raging watery diarrhea, but just stools to be loose. In fact, the women who are listening to this may also realize that they experience the same thing during their menstrual cycle, because prostaglandins are high at that time as well. That causes the uterus to contract or causes us to have cramps during our menstrual cycle. It'll also cause us to have loose stools, perhaps. True labor versus false labor. There is in your textbook on page 329 a patient-centered teaching, or how to know whether labor is real, chart. And I would like for you to read that and be familiar with those signs and symptoms of false labor versus true labor. So I'll let you study that on your own, but I would encourage you to study it. Now here's a question. Which one of these abbreviations represent the fetal presentation and position that is most favorable for a vaginal birth? Well, after we go over this in class, if you're not sure now, you probably will be sure. And of course, there is A, LOA, left occiput anterior. So let's move on to the stages and phases of labor. There are 4 stages of labor: first, second, third, and fourth, each marked by very specific actions and events that occur during these phases of labor. And the first stage, as I mentioned earlier, I think, is the only stage that has 3 phases. The first stage of labor is all about dilatation and effacement. We go from 0 centimeters to 10 centimeters of dilatation, from 0% to 100% of cervical effacement. That's the whole point of the first stage of labor, dilatation and effacement. It can be further divided into phases so that we can get an idea of where this patient is in relationship to delivering her fetus. And of course, that can change at any time, actually. We can have a woman who appears to be in the latent phase, and within 30 minutes she could come in and deliver her hospital, or perhaps maybe have one of those precipitous births, an unattended birth in a cab or with her husband in the car or whatever. So the phases are important to us because we know that we need to do certain interventions or can do during that, but know that it can change at any time. Mom and fetus can take over and change their mind at any time. During the latent phase or the early phase, that's usually when the patient is about 3 to 5 centimeters of dilatation. That's where it's different from my chart because your book uses 3 to 5 centimeters, which is a little confusing because active is 4 to 6. So there's a little overlap. But again, this is our textbook and that's what we're using. So the latent phase of labor is 3 to 5 centimeters of dilatation. The active phase of labor is 4 to 6 centimeters of dilatation. And then transition, often the most contractile, the most difficult. Fortunately, the shortest phase is when the patient is about 7 or 8 centimeters to complete. So that would be 10. Okay. So again, 3 to 5, 4 to 6, and 7 or 8 to 10. Okay. Those are the different phases. Now, a woman feels totally different in the latent phase than she does in the active and transition phase. During the latent phase, many women are at home. They're walking around, maybe having some clear liquids or a little soup or something like that. However, they don't have to be hospitalized unless their water has broke or their contractions are those X minute apart that the physician told them to come to the hospital. In fact, it's better to be home in the latent phase if you can. During the active phase, and during the latent phase, the patient, when you go in to do their intake, they'll be on their telephone, talking to their friends. Oh yeah, we're here, blah, 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 doing all kinds of other things, setting up their room, talking to their partners. And they're very animated and happy and excited, maybe nervous or anxious, but they know what's coming and they're ready. They've been ready, okay? During the active phase, she's not going to be quite so animated, probably not accepting phone calls, very little texting or watching TV. She's going to be focused more on herself and the process of labor. She'll either be asking for her epidural or IV push medication, or she'll be using her hypnobirthing, slow deep breathing, other types of distractions, looking at pictures, aromatherapy, and other types of things that are helping her to cope and manage her pain. During the transition phase is the phase where she might do something like Bill Cosby's wife did, like stand up in the stirrups and yell, "I want morphine," or tell everyone in the delivery room that his parents were never married, that kind of thing. Women will say things that they often don't mean. This also when if they're going to throw up or puke or barf on you, this is when it's going to happen. So this is why we don't want to give them large amounts of food because that motility of the gut is just really, really slow during the process of labor. So she does become more anxious and irritable. Sometimes we need to hold on to their face even almost, get them to look at us, say, breathe with me, focus with me, really keep their attention while this process is going on, the transition process. We call it the storm of labor. Fortunately, it's also the shortest. It could be from minutes alone. In your textbook on page 333 is a graph at the top of the page called Composite Normal Dilatation Curves. This is a Friedman's curve. Dr. Friedman made this graph in the middle 50s, I think around 57 or so, based on a small group of women, or a small N as we call it in research, about 250 women who were all Caucasian and all middle class. The interesting thing about that, besides that, is that we're still referencing this Friedman's curve in spite of the fact that many of our demographics have changed. Certainly our process of labor has changed, use of epidurals of 80 to 90% in some facilities, mixing of races more than we did before, so not just Caucasian, but multiracial fetuses are being conceived and birthed. You can see here that a multiparous woman, down the left-hand side is the cervical dilatation. Across the bottom are hours. So if you look at the red curve, the multiparous woman will deliver in about 7 hours, and then the nulliparous woman will deliver more towards the 13 hours. Okay, so we have a woman who says, "Oh yes, I had a very, very, very long labor. It was so long." And you find out it was 12 or 13 hours, then you'll be like, "Oh, okay." You just say to yourself, "Okay, it was a normal labor." But I assure you, to that woman, in fact, it was a very long, difficult labor. Okay? So nursing care during the process of admission is, of course, we have to establish a therapeutic relationship. In an ideal situation, we have plenty of time to do this. This will be in the latent phase or not too far into the active phase when she's admitted. Or perhaps she'll even be admitted more likely in this day and age for induction. So establish a therapeutic relationship with her just like you do with your other patients by introducing yourself, your role while she's there, the orientation to the room and the equipment, and when she may need to call you or not. And then, make contracts or pacts with her. I will do this, you will do this, I'll show up here or there, and then do that, and that will establish trust with your patient. We'll, of course, be assessing the mother and the fetus. In the mother, we're going to be assessing not only her vital signs, but all the different pieces and parts of her labor status. In the fetus, we'll be assessing fetal heart rate and everything that we can get from our cervical checks to the electronic fetal monitor, because that's really all we have to go on in that case. The assessments that we'll do on the mother in the first stage include her, as I said, her labor status, so that includes her effacement and dilatation, and the station, which we haven't talked about yet, but I will tell you what that means in just one moment. And then the membranes, whether they are intact or not. I believe I mentioned to you last, or maybe not, but on the membranes, when they rupture, there are 4 pieces of information we want to know, and we can use an acronym to help us remember them. We also share this with our patients because often their membranes will rupture at home, and we would like for them to note this information as well. So some people use the acronym TACO or TACO, but you could also turn that around to COAT, COAT. So it means time of the rupture, which is important because after 24 hours of rupture, we know that this patient is more likely to experience an intrauterine infection. The amount, whether it was a dribble, a small amount, or a gush. C for color. It should be straw colored, yellowish. It should not be green, black, red, brown. And the odor. It could have an earthy odor, a healthy odor, but it should not smell rancid or nasty or make you want to throw up. Okay? Fetal position, which we've already talked about and we'll demonstrate more in class. We want to assess our patient's comfort. And now remember, as we talked about in the pain chapter, even as we assess her comfort, we don't want to intervene with medications or other interventions that she doesn't want if she's planning to go through a natural birthing process. So again, assess her comfort, document your pharmacological, and absolutely document your non-pharmacological methods of pain and pain management and the patient's desires. And then her contraction pattern, which we can get by palpation, but most likely we'll get it by electronic fetal monitoring. So the contraction pattern means the frequency, so the beginning of one to the beginning of the next, as well as the duration, the beginning of one contraction to the end of that contraction, and then the intensity, which most likely we'll get by palpation unless they have an intrauterine pressure catheter in. And then, of course, her vital signs. And don't forget her I and O. Remember that full bladder can definitely stop a fetal head from descending, so we want to make sure her bladder is empty. And then the support person, and how are they doing? Are they still just playing on their machine, their electronic device, watching TV? Have they gone to the cafeteria 4 times, on the phone? Or are they really supporting mom? depending on how they're doing, you may need to educate them to bring them into the process if possible, and if not, then you may need to be their support person. So remember, this is all the assessments, the basic OB focused assessments that we're doing during the first stage, which includes those 3 phases. So this is dilatation and effacement stage. During the first stage for the fetus, it says baby there, but it's fetus, we'll be looking at their fetal heart rate. Of course, we're looking at it on an electronic fetal monitor strip, and we'll look at some more specific pieces in just a little bit. We're looking for variability. Remember, that's the waviness of the line. The fetus needs to be able to respond neurologically and adjust the heart rate to movement or stimulation. So we want to see that the heart rate can vary. Also, we want to see that there are accelerations, which are a sign of fetal well-being. We want to look and see if there are any decelerations. And if there are any decelerations, which is a decrease in the fetal heart rate as opposed to an increase, we want to look and see what kind they are, how long did they last, how often are they occurring. And finally, though the word that we use to describe in one word, actually, variability, and the presence or absence of decelerations and accelerations is reactivity. You'll hear your nurses say, my baby looks good. My baby is reactive. What they mean is it has variability, the strip has variability, the strip has accelerations, and it does not have any significant decelerations. So when you hear that the strip is reactive, it kind of throws those other 3 components in there all in one word. Or if it's non-reactive, then of course that would not be a positive thing. This is fetal station. Fetal station refers to where is the presenting part of the fetus in relationship to a very particular spot on the mother's bony pelvis. And that spot is where that red line is drawn, where it says spine. It doesn't mean her spine, but her ischial spine. And those are little bumps. You can see them. And when I bring in my pelvis, I'll show you and let you feel them. You can feel these bony prominences during your cervical checks or your vaginal exams. Once we feel where the bony prominences are, we want to feel straight across. And is the presenting part, which 97% of the time will be the fetal head, is it at the level of those ischial spines, or is it above or beyond? If it's above, those numbers are negative, and this is measured in centimeters. So approximately 1 centimeter above is -1 and -2. Once you get above -2, that fetus is still ballotable or movable. Sometimes you'll hear that it's high or floating. That's not optimum. When that fetal head does not come down into the pelvis like we think it should, then that's not good. Labor is a process. So as the cervix begins to dilate, as the cervix begins to thin out or efface, also too, we should expect that the fetus should begin to descend into the pelvis. I assure you, when we get to 7 centimeters dilated, 180% effaced, and this fetus is still -1 or -2, we are concerned, because that's not what's supposed to happen. The process is supposed to happen all together. Fetal descent should occur as the dilatation and effacement progresses. Now, we may not know why at that point. It could be that the fetus is in a position that's not going to allow it to descend favorably. It could be that there's a fetal head that is too large for the pelvis. That's what we call CPD, or cephalopelvic disproportion, a large head and a small pelvis. Or presentation or position of the fetus could also play a part there. If something doesn't change and that fetus does not descend, then the only thing that would be done from that point in 2014 is that, or 2015 even, is that we do a cesarean birth. So that's station. This is a funny little picture that can help you remember, possibly. It says, the fetus says, I'm at 0. From here, it's all positive. I'm on my way out. Because from 0, the stations then become positive. So that may help you remember which side's positive and which side's negative. Now we can assess the fetal position or presentation by Leopold's maneuvers. There are 4 steps to the Leopold's maneuvers. The first one is that we feel at the top of the uterus near the fundus on either side. And this is quite deep palpation, in fact. And what we're feeling for is the smoothness of a back or the bony prominences of the knees, feet, elbows, hands. So that's what we feel at the top. We're also feeling for a nice rounded, squishy butt, okay, which would mean that this baby is head down. If we feel something nice and round but it's really hard, then that's the head and this fetus is in a breech position. So we start up at the top with our first maneuver and feeling for the roundness, and then for either a butt or a head, and then to discriminate between those two, either the hardness of a head or the squishiness of a butt. And then we move on down to the sides, and again, feeling the smoothness of the back or the bumps of the arms, legs, knees, the extremities. And then finally, we kind of grasp right above the symphysis pubis to see if we can feel a head. You may only feel this when the head is not descended into the pelvis, so not engaged, she hasn't dropped yet. And then the fourth maneuver is to feel in reverse of what you've just felt. So verify that the smoothness of the back is on one side and the bumps of the extremities are on the other. And then you'll have an idea of the position of your fetus. This obviously takes some skill and some time to learn that. So this is a real life picture of the palpation of the Leopold's maneuvers. The hand position is slightly different in that one on the left, but still they're feeling, what am I feeling here? Is it rounded? Is it hard or soft? Okay. And then the second one, again, feeling for the smoothness of the back or the bumps of the extremities, feeling for the head down under the symphysis pubis, and again, D is verifying the position. So I hope in that picture you can see how deeply, especially in picture B, how deeply she's palpating with her right hand there. This can be very stimulating to the uterus, obviously, so we want to be careful if she's not near term that procedure. So here's a question for you. After monitoring the fetal heart rate for 10 minutes, the nurse notices that the rate is staying at 175. The nurse is correct in classifying this baseline rate as what? It's tachycardia, because the normal heart rate for the fetus is 110 to 160. Anything sustained, not goes up and down like an acceleration, but a sustained heart rate over 160 would be tachycardia. A sustained heart rate less than 110 would be bradycardia. And of course, an acceleration goes up, but it also comes right back down. So monitoring the fetal heart tones, we can do this in a couple of different ways. We can monitor with an external or an internal fetal monitor. Usually we'll start out with the external fetal monitor, which some of you may have seen or will be seeing in your labor and delivery experience. And that has 2 monitors. In the picture there, you can see that the TOCO monitor, the one where it's the big white one there has the TOCO on it, that's measuring contractions. And then that small round black disc-shaped thing that the nurse is applying down low on her pelvis, that is the Doppler that will pick up the fetal heart rate. Very important to have a continuous fetal heart rate, a very libelous situation if you do not have a continuous good heart rate. If you don't, then you need to document that you don't, that you notified the doctor. Because if something bad happens to this fetus or this mother, I assure you somebody will say that's exactly when it happened. So at times we spend a lot of time readjusting this Doppler because the fetus is moving or the mother is moving or something like that. If we cannot continuously get it, or there are any concerns because of the rate or lack of variability or any other abnormality that we see on the fetal monitor, we may want to use the internal fetal scalp electrode, which you see at the top right there. Of course, in order to do that, you can see that the membranes must be ruptured. We must be able to get to the fetal head. You could put it in another presenting part, and meaning if it were a breech presentation, you could do that. But 97% of the time, it'll be the fetal head, and that's where we'd like to put it. And also, so they have to be effaced and dilated, and the bag of waters has to be ruptured. This is done by a physician or midwife or advanced practice. This is not a procedure that's done by a registered nurse. And I'll have some equipment in the classroom so you can look at that and we can discuss that. There are some patients who you would never use a fetal scalp electrode on, even if you wanted and needed the information from it. Can you think of anyone who that might be? Try to remember that this is an invasive procedure, that if the membranes have ruptured and now we're putting an appliance inside the uterus onto the fetal head, or even in the case of an intrauterine pressure catheter, this is inside the uterus. We've gone through a non-sterile vagina in order to get to the sterile uterus. So yes, it would be those patients who have any infections of the vagina, including herpes, hepatitis, HIV, and some other vaginal infections that may also contraindicate the placement of any invasive procedure during this process. Now on the bottom right, this is where we would expect to hear fetal heart rate or tones. I always start by asking the mom, where have they been hearing your baby's heartbeat? I start there. Many times it'll be there, especially if they've just come from the office and they're at the end of pregnancy, because the fetus doesn't move a great deal from that point. But you can see on the top where it says LSA or RSA, that fetus is in the breech presentation. Normally, if the fetus is head down, we're going to hear their heart tones way down in the pelvis. So you can see that the ROP, ROA, and LOA are all below the umbilicus. Okay, just depends on which side. Now, which side? Well, it depends on which side the back is on. We usually hear the heart rate better on the back. That's why if it says ROA, that fetus, the occiput of the fetus, is in the front on the left side. And we'll demonstrate in class so you have a better idea. It might be best to just recognize, realize, and remember that if a fetus is head down, we're going to hear their heart rate below the umbilicus. And if a fetus is in the breech presentation or head up, we'll hear it above the umbilicus. This is an example of a fetal monitoring strip. So we have some contractions, and you see duration. You can measure from the beginning of the contraction, and that means when it starts to go and to where it ends there. That's the duration. In this case, it would be each box is 10 seconds, so we can count them. 1, 2, 3, 4, 5, 6. So that contraction lasts about 60 seconds. Let's look at contraction 2. That lasts about 1, 2, 3, 4, 5, about 60 seconds. And contraction number 3, 1, 2, 3, 4, 5, about 60 seconds as well. And then we can go from the beginning of the contraction to the beginning of the next contraction. Now, to help us eyeball this quickly, you see on the bottom it says 1 minute. That's because 6 of those boxes is a minute. You can maybe kind of see that there's a dark line there for a minute. So if this is the beginning of our contraction, we can see 1 minute, 2 minutes, 3 minutes. So these contractions are about 3 minutes apart, lasting for 1 minute. We cannot determine the intensity because there's not an intrauterine pressure catheter here. So we cannot determine that from the electronic fetal monitor. We could palpate and determine whether it was mild, moderate, or severe, though. Okay. Now let's look at the fetal heart rate above. There are no decelerations here. There is good variability, and there are some small accelerations versus variability. But overall, that looks good. This is a strip showing minimal variability. So we have some contractions here on the bottom, but look at the fetal heart across the top. Almost looks like a straight line, almost like a flat line on an EKG monitor. This is a fetus that is experiencing some distress of some kind. Again, variability and accelerations are signs of fetal well-being. So we don't want to see this. This is a fetus that we may need to be doing some other interventions on or gathering some more data. This is moderate variability, and that's okay. Now, decelerations, we use, you may want to use this acronym called VEAL-CHOP. It will help you remember not only the type of deceleration, variable, early, or late, and we throw acceleration in there just to make it a good acronym with a word we can use. So variable, early, or late decelerations. But now we can also associate that very easily without having to memorize the cause. So variables are always caused by cord compression. Remember that the cord is like a hose and there are vessels in there. And anytime that becomes squished or compressed, the blood flow through that cord, i.e. to the fetus with its oxygenated blood, is decreased. Now I'm going to show you what these look like. In a very classic presentation, variable decelerations are V-shaped. So they're decreasing down and they're shaped like a V for variable. They don't always look that way in real life, but for our purposes, because we're not going to be experts, we're just going to be very basic, not experts. So variables are caused by cord compression. The cord can be compressed because when the water breaks, it goes underneath the presenting part, usually the head, and is compressed that way. It could be that there's a knot in the cord, which I'll show you in a moment. It could be that the cord is wrapped around the fetus's neck or other body part. Now remember, this is not choking the fetus so it can't breathe, because the fetus is not getting its oxygen through breathing motions in utero. Yes, they make those motions, but not for oxygenation. They're getting their oxygenation from the blood, from the placenta, from the mother to the fetus. So if it's wrapped around their neck, what happens is when the water breaks and or the fetus begins to descend into the pelvis, that cord gets stretched very tight because it no longer has as much length as it normally would coming from the fundus. So it gets compressed, it gets pulled very tightly, and so the blood flow through that is limited. Early is caused by head compression. So as the fetus begins to descend into the pelvis, the head kind of gets banged against the bony pelvis and causes an early deceleration, and that's okay. Remember, it's always okay to be early for class or dinner reservations, but it's never okay to be late, okay? But it's always okay to be early. Let's jump down to late. Late has many causes, some that are caused by the fetus, some that are caused by the mother, and we group them all in one big category called poor placental perfusion. Okay? Poor placental perfusion. We may or may not discover during the process of labor, even after birth, we may never discover why they were having lates, but we know that it's an indication that we need to follow up on, depending on how often they happen, how long they are, maybe how deeply they decelerate. But overall, it's poor placental perfusion, and it's an alarm for us. And acceleration, again, we just threw that in so it would make a nice word, means that they are well oxygenated. So again, a way to remember your decelerations is by using the acronym VEAL-CHOP. So this is an example of an early deceleration. The picture on the left very clearly shows that we measure from the onset of the deceleration, and then we will draw a little line down to where in the contraction this is occurring. Because early means it starts before the middle of the contraction. At the middle of the contraction, where the peak, the nadir, or the acme are, the top of it, draw a line straight through there. And anything to the right of that, any deceleration that begins to the right, would be called a late deceleration. Any deceleration that begins to the left is called early. And we'll draw some of these in class and on the board. So an early deceleration begins on the left side of the contraction, and it will end somewhere, over on the right. But that's not as important as where it begins. We always, when we look at what kind of deceleration is it, we must look at where does the deceleration begin? Where does it start to decrease? Where does the heartbeat of the fetus start to decrease? Then, if you use these steps, you won't mess up. Draw a line from there down, straight down through the contraction pattern. And is the deceleration, does it begin on the left side, which is early, or on the right side, which would be late? The picture on your right demonstrates sometimes these contractions will be called mirror image. These decelerations, early decelerations, will be called mirror images of each other. So their peaks sometimes touch. This is not always true, okay, but sometimes is true. They look like mirror reflections of one another. This is another picture of early decelerations. If you look in that first box, the nice smooth dip down, see where it starts to go down right under the number 3. If you look across the top, it says 83785. Look right down under the number 3. You can see where it starts to go down. Draw your line down to contraction, and you see clearly that it begins to decrease on the left side of the contraction. Again, it's okay to be early for class or dinner, but it's not okay to be late. So in this situation, the deceleration, the onset of the deceleration begins at the middle in this particular slide. So it will begin either right at the middle or to the right side of the contraction. Now, if you think about it, this makes sense because this is a fetus who's experiencing a deceleration, telling us, hey, things are not good here. I'm having some trouble in here. And yet think about, what is the mother experiencing in terms of her contraction intensity? Well, she's feeling better. The contraction is lessening, going away. She's experiencing less pain. The uterus is getting flooded back with blood again, and the placenta. However, the fetus is not okay. It's saying, hey, that was tough. It's taken me a long time. It's almost like they've got a hangover here. They're just not picking it up and getting it back together. Okay? So late decelerations begin at the peak or the acme or the nadir or to the right of the contraction. And we'll look at this in class. So this is a picture of a late deceleration, an actual picture. And if you look, let's look in the one that's most obvious. Let's look in between the 77588 and the 77589. And you'll see, I don't think that I can point with this thing, but you'll see that it begins to go down right about just to the right of the peak or the acme on that second full contraction. So that's a late deceleration. We'll look at some of these in class again too, so I can draw and help you see that. So again, just a little picture to depict okay to be early, not okay to be late. Now, variables are caused by cord compression. This is one example of a variable. This is of a compression cause. This is very rare and was actually shared with me by one of our adjunct faculty. And at that time, she said that everybody in the labor and delivery area, nurses, doctors, everybody came in to look at it because they'd never seen one. It's so rare. This is a true knot. Now think, how does something get in a knot when it's attached at both ends? Well, because it occurred very early, obviously, in development and embryogenesis. So this is very rare, but you can see now as this fetus, the water breaks and the fetus descends down into the pelvis, I hope you can see that this will be pulling very tightly. And now the knot is really tight. And so the blood flow is limited severely through that tight cord. I hope during clinical you're able to see a cord, look at the ends and see the different vessels. And what kind of vessels should be in there? Is it two veins and one artery, or two arteries and one vein? So hard to remember, isn't it? Not really. And if you haven't already learned it, learn the acronym AVA, A-V-A, artery, vein, artery. So you always know there are two arteries and one vein. Now, variables often look like a V for variable. Again, not always, but for our purposes they will. They're variable not because they don't occur early and they don't occur late. They occur anywhere. They can be variable. They can occur early in the contraction or late in the contraction. It doesn't matter. But they are depicting cord compression of some kind. Now, with earlies and lates both, it's not like if they just have one in a 10-hour process of labor. And what do we do about it? It's how often do they occur? How many lates are they having? How many earlies are they having? How deeply do they go down? How long does that deceleration last? In addition to that, we have to put together the other pieces of information. What stage of labor is this mom in? Is delivery imminent, or is she very early in the process of labor? Also, are there accelerations present? Is there variability present? With the absence of accelerations and the absence of variability, and the presence of variable or late decelerations, this is a much more serious case that we need to pay attention to and look at. Okay. That being said, sometimes fetuses don't tell us the truth on the electronic fetal monitor. We have beautiful looking strips, and unfortunately we sometimes have a poor outcome regardless of everything that we do is correct. And sometimes we have a really awful looking strip, and upon delivery everything looks perfect. The uterus looks perfect, the mother looks perfect, the fetus, now baby, looks perfect, the placenta, the cord, everything looks perfect. And we don't know why the fetus was sending those 911 messages basically from the electronic fetal monitor. We don't look a gift horse in the mouth at that point. We're just happy that everything turned out okay. So these are some variable deceleration. So if you look across the top with the fetal heart rates, you can see that very clearly those are V-shaped. That's representing cord compression. Now I will tell you, we're probably not going to do anything at this point because if you look at the bottom, it looks like they have plateaus on their contractions. That's because this mom is pushing at this time. Okay, she's pushing. So we may not do anything at that point. Just let it continue. All right. So, with a prolapsed umbilical cord, here are some basic things we need to do. You need to understand that when the umbilical cord prolapses, it's most likely to do that when the membranes rupture. This is why when the membranes rupture, the very first thing we need to know is we need to look for the worst thing that could happen at that moment. And the worst thing that could happen at that moment, at that very moment, is that the cord falls under the fetal head or the other whatever presenting part there is, and it's compressed so that the fetus is not getting any blood flow. So our first action is not to determine, well, gee, I don't know, did they break their water or not? That's not emergency. We have time for that. First emergent intervention is to determine the fetal heart rate. We need to get a pattern on that kid, so we need to hook them up to the monitor. That's why we ask them to come to the hospital when their water breaks, as soon as their water breaks. So this tells you what you do with it. This is an obstetrical emergency. Some nurses call this riding the stretcher, and some nurses really like to ride the stretcher because they literally get up on the stretcher or in the bed with the patient with their gloved hand, pushing up through the vagina, pushing up the fetal head or the presenting part that's compressing the cord, and they stay there until when? That's right, until the fetus is delivered. They stay there through the draping procedure. They stay in that position, and of course they'll still be monitoring so they can see that the fetus is well oxygenated. They stay there while they do the whole surgical procedure, well, until they get the fetus out, and then they get to come out. Okay. You notice it says give oxygen. Well, the mother's fine. Why are we giving the mother oxygen via a mask? And let me just say, in OB, we don't play with oxygen. We use oxygen. When we want to give oxygen to the mother, we always deliver it by mask. We always deliver it at 10 liters per minute. You never have to get an order for that. It's on a standing order, and it's always available to us to use. Of course, the physician would be notified of any change in the woman's condition immediately, but we don't have to wait for them to give the oxygen. So the reason we give the mother oxygen, even though she doesn't need oxygen, is because it's the only way to get oxygen to the fetus. So anytime we think we want to get oxygen to our fetus, we give oxygen to the mother. And again, we don't play. We give mask at 10 liters. Another picture of some beautiful variable decelerations. These are recurrent though, so if that were continuing and lasted, I will tell you we don't make a diagnosis of something or do anything necessarily major until 10 minutes, because that's 10 minutes. And let's see how many this is. 1, 2, 3, 4, 6, 7, 8, 9, 10, like 12 minutes. So diagnostic really is 10 minutes on a monitor strip. That's not to say if we have a fetal heart rate that's going at, 142, 144, something like that, and it drops down immediately to like 60 and stays down there, we're not going to wait 10 minutes for that. Okay. However, 10 minutes is usually what we use. Now, how do we report what's happening? In the past, we used simple words like this is a reassuring fetal heart monitor strip, or a non-reassuring. Reassuring meant pretty much what it says here in category 1, and non-reassuring meant like category 2 or 3. But what we found was that communication between nurses and doctors was not very good, and often we needed to communicate more clearly. Physicians would say, well, I didn't know that's what they said. If they had known that, I would have come right in, or whatever. So in 2008, the National Institute of Child Health and Human Development established these guidelines. I hope you're hearing it in clinical, but I cannot say that you always will. Some nurses are still using the old nomenclature. But we should be saying to physicians and midwives, we have a Category 1 strip, we have Category 2 or 3. I won't expect you to memorize all of these, but I would expect you to recognize a Category 1 strip because it has everything in it that we've been talking about. It has a baseline fetal heart rate of 110 to 160. You know that's normal. We know that there's variability present. It says moderate here, but at least we have some variability present. You would not want to see that it was absent, okay? You want to see that you have some kind of variability. Late or variable decels, you would like to see those not be there. So absent, I think we've talked about that. Those are not necessarily good things to have happen, especially on a recurrent basis. Early decelerations can be present or absent because it doesn't matter. We don't care whether they're there or not. They're normal. There are no interventions for early decelerations. None. We note that they're there, but we do nothing because it's not a problem. And then accelerations can be present or absent. So I'd expect you to be able to notice a Category 1, and you would know then that this fetus has an adequate amount of oxygen. It's well oxygenated. So its fetal acid-base status is normal. It's not acidotic. It's normal. It has not too much CO2. It has enough O2. Okay? So when we report this information, we don't have to use all of those pieces of data. We can say to the physician, we have a Category 1 monitor strip from the fetus. They know exactly what that means. And then when they get to Category 2 and 3, you can see where things start to deteriorate. We would always be reporting this. There are certain actions we were going to take. In the meantime, while getting the physician on the phone, we won't wait until they call us back necessarily, but we will continue on with our interventions and notify the physician at the same time. So how do you do that? Well, you get help. You can't do it by yourself. You have a team, and you use your team to help you. When you have a problem, often you don't even have to call your team because the alarm goes off at the nurse's station where the charge nurse or some other nurse is watching the monitors overall, because you may not be in that room at that moment, and other nurses will come to help. And we're very calm about it usually. You just put on the call light. I need some help in this room, please, and they'll probably already be there when you do that. So these are some interventions that we might use for non-reassuring fetal heart patterns. We would like to identify the cause, but I assure you if we don't identify the cause right away, we continue right along anyway. We want to increase the placental perfusion. We want to get more blood through the placenta, more blood and therefore oxygen to the fetus. We want to do that right away. So we change positions. Optimally, we'd like for the mom to be on her left side. That increases the blood flow through the aorta. So we place the mom on her left side. If she's already on the left side when this is occurring, then we'll turn her to her right side. If that doesn't resolve it, at the same time we're doing these other things, if that doesn't resolve it, then we'll put her in the head, the knee chest position. Now she's not going to be able to do that if she has an epidural in place. So we'll put her head down on the bed and the foot up. Now what is that called? Is that Trendelenburg or reverse Trendelenburg? So easy to get confused, so hard to remember. Well, a student several years ago gave me a hint, and Trendelenburg is always butt up, head down, because he said it's trendy to be butt up. So butt up is trendy or Trendelenburg. So if you know that and the butt's up, then you know the head's down. I hope that doesn't offend anyone, but it's an easy way to remember because at times over the years I've gotten confused. We also want to give them sometimes more fluids because dehydration can cause some of these problems. So we want to increase their fluids. A tocolytic, which we'll talk about more in the future, a tocolytic is a medication that relaxes the uterus because in fact we might want to stop these contractions if we can, or at least decrease the intensity or frequency of them. So we'll use a tocolytic. And for now, let's just learn tocolytic, and then we'll learn some more specific medications in a little bit. And we might want to decrease or turn off our Pitocin or oxytocin if the patient is being augmented or is being induced with Pitocin. And I can't tell you which exactly those will happen, but that may that may occur. And then we want to increase the maternal blood oxygen saturation. And again, we do that by face mask at 10 liters. And reduce the cord compression. We can reduce cord compression in sometimes by doing a procedure called amnioinfusion. This is a procedure where we insert the intrauterine pressure catheter, which I'll show you in class, and we connect that to a sterile bag of IV fluids, and the IV fluids flow through the tube into the uterus and can reduce the pressure sometimes or release that pressure from the cord. Okay, so we can use that. Again, this is one of those procedures that are invasive. We would never want to use it if the mother had any kind of infection like HIV, Hep B, an active case of herpes, or some other types of vaginal infections. So these are the basic initial interventions that would be included on a protocol or standing orders for labor and delivery if we had something a category 2 or 3 non-reassuring fetal heart rate. We would change the position of the mom, increase the fluids, perhaps give a tocolytic, turn down or turn off her Pitocin, give her oxygen 10 liters by mask, and perhaps do an amnioinfusion if she already had the IUPC, or at least set up for it, knowing that this might be what might be the next thing when the physician or midwife comes into the room. Now, all of what we just discussed over the past hour or so was stage 1, the assessments and everything that we might encounter and do for the fetus and the mother in stage 1. Remember, stage 1 is complete effacement and dilatation. Now we can move on to stage 2, which is the delivery of the baby, basically. Stage 2, there's crowning and cardinal movements, and we'll move on here now. This is a video that you might want to watch. This is stage 2. You might have seen it. It was a YouTube sensation, but it's very entertaining, so you might want to use that. The dad had a GoPro on. He was not holding a camera, but he did have a GoPro, and that's how he was able to do that. But it was entertaining to watch for a few minutes. A depiction that shows you the stations of delivery in relationship to delivery. If you remember, station 0 is when the presenting part is at the ischial spines of the bony pelvis, and then positives after that by centimeter 1, 2, 3, and 4 on the floor. Plus 4 is on the floor, kind of like that tequila thing, 1 tequila, 2 tequila, and then somebody's on the floor. Anyway, once they get to plus 4, then they're delivering at that. Now, the fetus is not just a passenger with no activity or no responsibility during the process of birth. In fact, they are making lots of movements, and the movements that they are making are those that you see here before you. They will descend and engage, and then they move down to the different stations, and then they flex. Flex means they put their chin on their chest. Okay? It flexes even farther than it did before, and again, this allows the smallest diameter of the fetal head to be presenting and to come through the bony pelvis first. And then there will be some internal rotation. So internal rotation, this is where whether they are posterior or anterior comes into play, because if they only have to turn from an occiput anterior position, then that's more advantageous. So if you look at picture number 5 on the top right there, that fetus is in an occiput anterior position. So it only has to rotate slightly to get into the position for delivery. And if they were in the posterior position, they have to rotate all that way around themselves, and that can take a long time. There are some different things we can do to encourage that by positioning the mom in certain ways, putting her on the birth ball, and some other things that we can do if she's in the bed. But that is necessary. And then finally, there is extension as the fetus comes out. The fetus will stick its head out, and you notice that it's born facing down. Okay, and then it will turn externally, and then it will come out. Crowning means that the fetus is pushing against the perineum, and I think we'll see this in a movie that we'll show, or you may see it in real life. But the perineum is really, really bulging, and sometimes you can see the fetal head and the hair at that point while they're pushing. Now, how long it takes to push out a baby may depend on the fetal size, the pelvic size, whether it's the first or subsequent deliveries. Usually the pushing and the delivery of the fetus gets shorter with each subsequent baby, but not always true because it can depend on the position. So it can be anywhere from 1 push to 2 hours. Once a patient gets to 2 hours, and if the fetus and the patient are doing well, they might be granted a little bit more time, but maybe not. At that point, they'll probably decide whether they would want to do an assisted delivery with forceps or a vacuum, or take this patient to the operating room for a cesarean birth. So any time, it could be few pushes to a lot of pushes. Friedman's curve comes in here because Friedman said it should take a woman about 2 hours to push out her first baby. Again, we could grant her a little more time as long as good progress is being made and she's not too exhausted. But I will assure you that that's not the case usually. After pushing every couple of minutes for 2 hours, a mom is very tired. So she's going to need help to get that fetus out, or with assisted delivery, vaginal delivery, or cesarean. So this is a YouTube on getting in a position, and the picture on the left, it shows a mom who obviously has not had a epidural because she's squatting in the bed holding on to the birthing bar, and that's a very, very good position, often feels very good and comfortable to the patient. She could do that on the floor, but that wouldn't be terribly sanitary, so we usually just do it on the bed with the birthing bar. She can also lean on her knees over the head of the bed, and then that gives a place for the support person to be. It's a really good position, and again, gets her in that positive gravity flow position that can feel so very good. So feel free to watch that as well. And that's what we've been waiting for. And that fetus is covered with white goopy stuff. What is that called? Oh gosh, I don't know. It's vernix. Very good. So now we move on to the third stage of labor, and the third stage of labor is the delivery of the and sort of like the delivery of the baby, the placenta can be delivered very quickly, so in 1 or 2 contractions or pushes, or it can take up to 30 minutes and still be considered normal. At any time that it goes beyond 30 minutes, we begin to be concerned that this may not be a delivery that's going to occur naturally or easily or safely, because it could be that the placenta is implanted not only into the endometrium but into the various levels of the muscle of the uterus, and that is an obstetric emergency. It can cause a severe postpartum hemorrhage and often result in and most always result in a hysterectomy on the part of the mother, which sounds good. Okay, we saved her life, but if it's her first baby and she wanted to have 4, 5, 6, or 7, then she's not going to be able to do that again. So it's a significant event. When the placenta begins to separate, we usually see a gush of blood. The umbilical cord will look like it's getting longer or protruding out of the vagina just because the uterus is descending, and that's what's happening in that case. And so we'll know to expect the delivery at that time. The placenta can be delivered either with the maternal side, or the red beefy side, showing first, or with the fetal side, the shiny side, showing first. The maternal side showing first, the red beefy part, is called Dirty Duncan, and the fetal side showing first, the shiny side, is called Shiny Schultz. I don't think it has anything to do with anything. If you'd like to see a delivery of a placenta, then you can click on that video. It lasts about 30 seconds, and you may watch that. So the assessments during the third stage of labor include inspecting the placenta. We want to see that all the pieces and parts are there, and that's what we're doing for the mom. And now a lot of and the A shows a delivery of Shiny Schultz, and B shows a delivery of Dirty Duncan. Excuse me. And the third stage is all directed now towards the baby, pretty much. We want to get our APGAR score on our baby, so you can see down there in the chart, table 19-7, the APGAR scoring. We evaluate the heart rate, the respiratory effort, the muscle tone, the reflex irritability, and the color, and get a score of 0 to 10. You can have odd numbers on this, so anywhere from 0 to 10. Most babies are born with 8 to 10. Very few are born with 10, more 8s or 9s. So we want to get their vital signs. The umbilical cord will be clamped as in the picture that we see here, and you see the large vein and the 2 arteries there as well. Estimate their gestational age if you're in a facility that does that, so use the Dubowitz or the Ballard scoring. Some facilities only do this on preterm babies, not term babies. Identify, so place the ID bands according to the facility. Of course, 1 ID band will go to the mother, 1 ID band to the fetus. The fetus will often have at least 1 more ID band, and sometimes 2. Some facilities put 3 bands on the baby, some put 2. And then there's another ID band that can relate someone to, excuse me, to the fetus. And this is where sometimes in dysfunctional families we have some problems. The mother chooses who that other person will be to have the band, and the only thing the band does is give the ability of the person with the band to transport the newborn back and forth to the nursery or to walk it in the hall. Only people who have an ID band can be in the hallway out of the mother's room with the newborn. However, if we have 2 fathers or a father and a mother of the baby fighting over it, this can be quite challenging at times. And then, of course, do our initial physical assessment on the newborn. And just a cute picture of Hello Kitties I found. Obviously, all girls. The 4th stage of labor is the first 4 hours after delivery. The assessments that we do on the mom, of course, are those that we've talked about already in the postpartum section, which was covered on our first quiz of this course. So we're getting vital signs, we're assessing her fundus, and remember initially after delivery the fundus will go down midway between the umbilicus and the symphysis pubis, but then in a very short time will rise back up to the level of the umbilicus, and that's where it will be on delivery day. And then every day after that, it will descend by 1 centimeter or 1 finger breadth. So on postpartum day 2, the top of her uterus or the fundus should be palpated 2 finger breadths or 2 centimeters below the umbilicus. It's always okay to be an overachiever, so it's okay to be descended farther than you would expect. It's not okay to be descended, to not be descended where you should be. So if you're above where you should be, that's not normal for the patient who's in the postpartum period. We want to evaluate her lochia, and some facilities do this by percentages, and some do it by inches or centimeters on the peri-pad. So you just have to accommodate to the facility whatever they're doing there. And perineum, if the mom has had a vaginal delivery or not, we're going to always assess her perineum because she could have pushed and didn't have any suturing or anything, but by pushing she has predisposed herself to a perineal hematoma. So we'd want to make sure we were evaluating for that. In addition, she could have hemorrhoids. So when we assess the perineum, we also are assessing the rectum at the same time. So even a mom who has not been in labor but has had a cesarean birth, we still need to look at her bottom side at least once so we can document whether she's had any hemorrhoids or has any hemorrhoids now that she may need help with. And then assessing the bladder continues to be important here, not for the reason of the fetal head descending, but for the reason that the uterus won't be able to contract and get down into the pelvis if the bladder is full. So we want to make sure that the mom is either evacuating her bladder or that we are evacuating it with a straight cath or a Foley. They should void at least 250 milliliters with their first void. If it's a small amount, then it may be that her urethra is swollen or irritated and she cannot void, or it could be that's all she has. So in order to know that, we need to assess her bladder. We can palpate to see if her bladder is full, or we could use a bladder scanner if you have it. And many, believe it or not, many OB floors do not use a bladder scanner for whatever reason. Finally, we want to assess her level of comfort and make sure that she's comfortable and if she needs pain meds to give them. In the fetus, we'll continue to assess by assessing vital signs, their color, any mucus that they might have. This baby's being suctioned here, but usually we'll use a bulb suction. We keep the bulb suction with the baby at all times in the hospital. Wherever the baby goes, their bulb suction goes. And the first time that we leave the baby alone with the mom and the family, we make sure that they know how to use the bulb suction as well. We want to note their movements. Are they moving all of their extremities, or are they moving only their right arm and their left arm remains laying down at the side of them? That could indicate, especially in a large baby, that the baby may have a fractured clavicle, because when they move their arm, if you have a fractured clavicle, it hurts, and so they don't do that. Or if it was an assisted delivery, then there could have been some sort of injury to the brachial plexus. And note their behavior. Babies right after birth will have a period of reactivity where they're awake and alert and just happy to be out, and it's a great time for bonding and attachment to occur. And then they may cry when they're hungry, and then they sleep, and that's pretty much what they do. They cry when they're wet, they're tired, they want to be held or fed, and then you take care of those things and they go back to sleep. A baby who does not respond to the normal meeting of their needs, there may be something else involved, such as substance exposure.